بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Good evening, friends, colleagues from different in Oman and from outside. Thank you very much for joining this webinar. On behalf of Oman Medical Association, would like to welcome you to the first webinar actually to be conducted by Oman Diabetes Association. And we are glad today to have with us Dr. Ali Al Ressi. Dr. Ali is a consultant endocrinologist and HOD, Department of Internal Medicine in Sohar Hospital here in Oman. And he is one of the active actually member and in the community in terms of educating both public and healthcare provider for issue related to medicine and particularly endocrinology. And he is also he's also an educator for medical students and residents. So we are going, inshallah, to have first his presentation for around maybe 45 minutes, and then we will open discussion. So for question, you can put it, if you would like to put it on writing, you can put it in the chat box. There is a chat box, and just write it there, and then we'll read it together at the end of the lecture. Or you can raise your hand. There is one button there. You can raise your hand, and then I will give you I will call your name, and I will give you the microphone to give your question directly. I would like also to ask all of you to mute your microphone because it will cause a lot of interference. So please mute your microphone until we finish the lecture, and we'll get to the presentation. And also would like to mention that this presentation is recorded. So if you ask question like verbally, it will also be recorded, because we would like maybe to again broadcast it list in our social media in the Oman Diabetic Association. So Dr. Ali, first of all, thank you very much, and Ramadan Kareem, and welcome to Oman Diabetes Association, and thank you for your cooperation. And now I will give you the stage to give your talk as we discussed, and then we will move to answer and a question and answer session at the end. So you are most
welcome. Thank you, Dr. Ahmed. Thank you, Oman Diabetes Association also. بسم الله الرحمن الرحيم الحمد لله والصلاة والسلام على أشرف الأنبياء المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. Thank you all of you. And because of pandemic corona, now we are using social media and technology, and it is good. It is good. It will give us a chance to participate in today. Our lecture will be about management of diabetes in Ramadan.
واضح واصل دكتور، واضح صوتك. It's clear.
ما أعرف. I can't control
the same way used before. Just put it on the projection and then you move by. Yes, now it's now it is working.
Okay. Again, Assalamu alaikum wa rahmatullahi wa barakatuh. Today our talk will be about management of diabetes in Ramadan. Before my talk, just to tell you about all of my presentation, I got it from two very important guidelines. The first one, Diabetes and Ramadan Practical Guidelines from International Diabetes Federation in cooperation with Diabetes and Ramadan International Alliance. And the second one also same. I advise all of you just to have a look later. My objectives in today's lecture will be after introduction. I will mention some challenges between healthcare professional and patient during Ramadan. Before we are talking about how to manage patient with diabetes in Ramadan, we have to know some of obstacles we face on daily basis, and also the epidemiology of diabetes and Ramadan fasting, risk associated with fasting in people with diabetes. And this gives us idea why we have to talk about this important topic, and factors for risk quantification, and how to do risk stratification of patient with diabetes during Ramadan, and components of education. Education is very important. If you receive one home message today from my lecture about the importance of the education, and when to break fasting, when the patient is insisting to fast, when they have to break their fasting, and diabetes management during Ramadan. As you know, fasting during Ramadan is one of the 5 pillars of the Islam. And as you know, the mandatory for all healthy adult Muslims to fast. So within the Muslim community, there is intense desire to participate in fasting. You will find some people, they are not regular in prayers. But when Ramadan comes, they have intense desire to participate in fasting, even among those who are eligible for excuse. The timing of Ramadan is based on Islamic calendar. So, which means that the start of Ramadan differs from year to year. In some parts of the world, the daylight can last up to 20 hours in the peak of the summer. So climate conditions also differ according to the date of Ramadan, with people fasting in very dry and hot weather some years. For example, in last few years, most of our Ramadan were in summer, and this make fasting for our patient is very difficult compared when they are fasting in winter. And as you know, or as you see, this year the Ramadan started with summer. Okay, what are obstacles between doctors and patient? Ramadan fasting therefore represents some challenges between healthcare professionals and patients. It is very important, long duration of fasting period. As you know, we are fasting almost 15 hours, from 4 till 7. And this makes the difficulty for our patient, especially patient with diabetes, especially type 1 diabetes and some type 2 diabetes who are on insulin. They are prone to develop hypoglycemia, and also some patients may have hyperglycemia because of the long duration of the fasting period. Rich carbohydrate meals during Ramadan, we have to consider that we don't ignore our habits and our traditional meals, especially during Ramadan. And most of our patients will be involved in those rich carbohydrate meals. Uncontrolled diabetes. Still, we have some patients with uncontrolled diabetes, and those patients are associated with the risk of hypoglycemia and hyperglycemia. And in type 1 diabetes, they are prone to develop diabetic ketoacidosis. Yes, most of our patients are still in insulin in BH and regular, and some patients on glibenclamide. And as you know, these agents are associated with hypoglycemia compared to other medications like insulin analog or other or other sulfonylurea or other medications like metformin and sitagliptin, for example. Fasting Muslims tend to avoid counseling their doctors during Ramadan and before Ramadan. Why? Why? Because fasting Muslims tend to avoid counseling their doctors during Ramadan and before Ramadan. Why? Because if we don't study or educate patient in well-structured education, they may, as I said, there is intense desire for most of the Muslim to fast and participate fasting. So when we are not flexible and when we don't allow them or help them to fast, they will avoid us. So we have to know how to be flexible and how to educate them and how to help them to fast during Ramadan. Sleep pattern changes during Ramadan. As you know, now almost for more than 1 month or 6 weeks, most of our people are on leave because of the pandemic corona. So usually they will sleep all of the day and will be awake all of the night. And this will make our patient, especially in day, they will be prone to develop hypoglycemia. If the patient will develop, or if the patient receive insulin at suhoor time and he will sleep, for example, for 6 or 8 hours, he may develop hypoglycemia during sleeping. And this is one of the challenge for our patient. So this is very important study. EBDR study found that. So in spite, we are educating our patient not to fast, and we give them the but this study showed that almost 43% of patients with type 1 fasted at least 15 days, and 79 of patients with type 2 diabetes fasted at least 15 days during Ramadan. And another study called a CRED study reported that in type 2 diabetes, in this study, almost 94% of patients fasted for at least 15 days. So this is very important home message. Most of patients will fast. So to advise them not to fast is not the solution. We have to educate them how to fast and how to adjust their medication and how to break their fast, to break their fasting. So as you say in this study, CRED study, 94% fasted more than 15 days. More than 94 of type 2 diabetes fasted more than 15 days, and only 6% fasted less than 15 days. And from 94, from the total of 94, 67.6 they fasted every day, and only 32 fasted less than every day. So what are risks associated with fasting in people with diabetes? It's very important. Hypoglycemia, especially patients who are on insulin and sulfonylurea. Hyperglycemia, especially for type 1 diabetes. They may develop diabetic ketoacidosis, and especially in elderly, the fasting may lead to dehydration and thrombosis. So the risk associated with fasting: hypoglycemia, hyperglycemia, diabetic ketoacidosis, dehydration, and thrombosis. In hypoglycemia, The EBIDAIR study recorded that more than 5 times patient may develop hypoglycemia in Ramadan compared with before Ramadan. And majority of these episodes required further assistance or breaking of the fast. So when the patient are fasting during Ramadan, the chance to get hypoglycemia 5 times compared to pre-Ramadan. Another study in Pakistan showed that 35% of patients involved in the study developed hypoglycemia in type 1 diabetes, and 23% developed hypoglycemia in type 2 diabetes. So, and this study showed that the most the okay, and this study showed the most time for hypoglycemia before iftar at 5 and 6, between 5 p.m. and 6. So most of the hypoglycemia developed before iftar. So for the hyperglycemia, EBIDAIR study showed same. The chance to get hyperglycemia is more, and also the same study in Pakistan carried by Al-Hamadani showed that 33.3 developed hypoglycemia between or among type 1 diabetes and 15.4 among type 2 diabetes. So what are factors for risk quantification? Type of diabetes, very important. When we decide patient is able to fast or not, we have to know type of diabetes. Usually, type 2 diabetes are able to fast, but type 1 diabetes, they have difficulty in fasting. Type of medication. In type 1 diabetes, if the patient is on insulin, MPH, or regular, they are prone to have hypoglycemia more than compared patient who are on analog. And in type 2 diabetes, patient who are on metformin or DPP-4 or other medications the chance to get hypoglycemia is less compared to patients who are on insulin or sulfonylurea. The presence of complication and comorbidities are very important. If the patient has long-standing diabetes with established chronic microvascular and macrovascular complications, usually they will not able to fast compared to patients who are newly diagnosed. Personal circumstances is very important, and we have to know that patients who are controlled diabetes usually are able to fast compared to patients who are not controlled. If the hemoglobin A1C or patient more than 10, usually they have difficulty to fast compared to patients who have hemoglobin A1C between 6 and 8. And also the episodes of hypoglycemia and hyperglycemia and diabetic ketoacidosis in last 3 months will help us to decide if the patient are able to fast or not. A previous Ramadan experience is very important to decide if the patient will able to fast or not. Okay, This is risk stratification of patient with diabetes during Ramadan. So this is very important. They put patient with diabetes in certain group. They divide them into categories: very high risk, low and moderate risk. Patients who are very high risk, they advise them not to fast. They must not fast. They must not fast. They advise patient not to fast at all. Okay, who are those? If the patient has one or more of the following: severe hypoglycemia within the 3 months prior to Ramadan, usually we advise them not to fast. Severe hypoglycemia required admission in last 3 months. Unexplained diabetic ketoacidosis was within 3 months prior to Ramadan, and those patients required admission or ICU admission. Hyperosmolar hyperglycemic coma within 3 months prior to Ramadan, usually advise them not to fast. History of recurrent hypoglycemia, and awareness. Poorly controlled type 1 diabetes. For those people, if they are fasting, they will get diabetic ketoacidosis soon. So we advise them not to fast. Patient with diabetes presented with acute illness, we advise them not to fast. Any pregnant lady with pre-existing diabetes or gestational diabetes treated with insulin, especially if the blood sugar not controlled, we advise them not to fast, because in the first trimester, if their blood sugar not controlled, this is associated and put the patient and their fetus at high risk for congenital anomalies. And in the last trimester is associated with polyhydramnios and macrosomia and neonatal hypoglycemia. And usually we advise them not to fast. Any patient with end-stage renal disease or chronic kidney disease stage 4 and 5, we advise them not to fast, because fasting, especially in summer time and long duration of the fasting, will put them at risk for dehydration and also sometimes hypoglycemia and hyperglycemia. Any advanced microvascular complication, old age with ill health. If patient insists on fasting, we categorize them as high risk, but they are insisting on fasting. They must receive structured education and to be under follow-up by qualified diabetes team. They must check their blood glucose on regular basis. We have to adjust their medication dose as per recommendation, and they must be prepared to break the fast in case of hypo or hyperglycemia, and be prepared to stop the fast in case of frequent hypo or hyperglycemia or worsening of other related medical conditions. The patient must know all of that before deciding to fast. Group 2, we consider them as high risk. If the patient has one or more of the following, we advise them should not fast. If the patient if the patient have type 2 diabetes with sustained poor glycemic control, will control type 1 diabetes, consider as high risk. Will control type 2 diabetes on multiple daily insulin therapy or mixed insulin. A pregnant lady with type 2 diabetes or gestational diabetes controlled by diet only or metformin. A chronic kidney disease stage 3. A group 3, we consider them as moderate or low risk. And usually they are able to fast without any complications. Those people who are well-controlled type 2 diabetes treated with one or more of the following: lifestyle therapy, metformin, acarbose, pioglitazone, second generation of sulfonylurea like gliclazide or glimepiride, DPP4 inhibitors or GLP-1 agonist, sodium glucose transporter 2 inhibitors, or patients who are on basal insulin. Usually they are able to fast. So patients who fast should receive structured education